more important is like knowing well about this, what you call CNS stroke as well as the epilepsy. The stroke, of course, it can be what you call your ischemic stroke or it could be a hemorrhagic stroke, where if the patient comes to you with these histories, then we have to have a record of these patients and then we should know how to manage these patients. In case of stroke patients, where it is always preferred to treat these patients most of the time in what we call in a upright position, as well as stroke is what? That is basically a bleeding in the CNS, or it could be an infarct in the CNS, wherever the bleeding or infarct is affecting, there the system, what we call the particular function of this CNS is going to be affected. So depend upon the area where it is affected the brain. But when you're managing the dental patients, these patients are mostly on the what we call the antiplatelet drugs, maybe, or maybe the patient's blood pressure is maybe under control, but still maybe dental treatment itself can cause a slight raise in the blood pressure and it can cause a secondary stroke. That's the reason this patient should be managed very well, or like you have to recognize these factors, what you call your anxiety of the patient, or where you have to treat the patients with a slightly, what you call this, without causing any much pain to the patient. And most of the time, this patient should be treated in this upright position. If the patient had a history of a stroke or whatever, that is it in the past 6 months, then it's better to like wait till the 6 months and later only we should take this patient for the treatment. Otherwise, if the past 2 months patient had experienced this, maybe the patient developed the stroke again. So it's better to wait for 6 months, then go ahead with the treatment, and then to prevent any what we call this morbidity related with this CNS stroke. Whereas the epilepsy patient, of course, the patients most of the time is going to have a what we call epilepsy patients, like when they come, then rather we should inquire about whether the patient is on a medication or with the medication this epileptic thing is under control, or when was the last episode, or was there any duration, what was the duration of the episode, whether the patient is required any hospitalization along with this epilepsy. And when we take up these patients, always like you inquire these things, and this assessment is going to give you the severity of the condition. If the patient is a long back, maybe 2 years back, if he has had a stroke or what we call epilepsy, then maybe the patient doesn't, it's all well controlled. So you can take this patient, and whenever taking up this patient, always have this in your emergency kit, that is diazepam as well as midazolam, and then you take up the patient for your surgical work on the dental chair. Whereas when you take the patient for the dental work on the chair, in this epileptic patient, make sure you should have the medications in your emergency kit, and then take up the patient if at all the patient develops the seizure from the chair, maybe because of our anxiety or what you call your surrounding environment, the pain. This can again exaggerate the condition, or it can lead to these patients are more prone for this again seizure activity. If the patient develops seizure on the chair, what to do? We need not to think of doing anything except protect the patient. The protecting the patient from untoward injuries because of this tonic activity of this limbs. Maybe sometimes the patient may fall from the dental chair. So you had to protect the patient during this injury from the untoward injuries, as well as we had to do the suctioning of the oral cavity, but don't ever dare to put a finger, because in the seizure activity where the patient is having what we call the contraction of this jaws, like where tongue is also bitten most of the time. So we should never try to put a finger in this between the teeth. Rather, we should always place a wooden small spatula or wrap with the gauze so to prevent the tongue injury, and maybe suctioning should be done. And then this is what we call a transient episode is going to be there always in case of epileptic patient. The patient is going to recover after 5 minutes. Once the seizure stops, the patient is going to recover. So our job is to just manage what we call protect the patient and prevent the tongue injury, and then do the suctioning of the thing. And later patient, once recovered, the patient is going to be in a slightly depression stage, or rather what we call a drowsy stage, where the oxygenation should be given to the patient so that the recovery is going to be rapid. Suppose if at all this seizure activity doesn't subside, then the condition could be a status epilepticus. That has to be terminated, otherwise this patient is going to develop the more complications because of metabolic derangements. Patient may end up with the unconscious stage. So we need to terminate the seizures by either giving the IV diazepam 5 mg, but not the IM, where this is going to act as only sedation but not as an anti-epileptic. Maybe 5 mg to 10 mg, whereas the problem with this what we call diazepam is that this is going to be the cardiorespiratory depression is going to be there, so that we should be trained to take care of the respiratory part of the maintaining the respiratory part of the patient, where you have to give oxygenation, or maybe if the respiration collapses, then you should be able to put what we call your oropharyngeal tube or whatever, So that should be learned. And then maybe better medication is going to be the midazolam, that is 1 to 2 milligram. It should be given to the patient in a diluted form in the IV so that the status epilepticus condition should be terminated. That's only emergency what you can encounter with this epileptic patients. So next patient, that is going to be what you call your cardiovascular system. So a lot of conditions are there, like angina pectoris, myocardial infarction, or a previous history of a heart attack, or maybe the hypertension, angioplasty, or a prosthetic valve replacement, or a history of a rheumatic heart disease, fever, or congenital heart diseases. A lot of conditions are there. But these are the few conditions that we should be aware when you are taking up the patient. Like first now is the angina pectoris patient. Whenever the patient comes with the history of angina pectoris to the setup or a dental clinic, then always ask patient to get their medications because they know better how to treat this. Whenever they get an chest pain, they're going to manage themselves by taking a medication. So always, like whenever the patient comes to the angina pectoris, make sure that the patient should get their medications along with them. And as you know, that angina pectoris is nothing but what they call a transient coronary spasm that leads to severe chest pain. That is going to be subsiding on its own if the patient takes a rest. That's the reason you have to, like when you take up the patient, always ask the medications. Ask the patient to get a medication, as well as rather we should also have these medications in our dental setup. And once you take up the patient on the dental chair, if you feel there's the same history like when was the last attack, what was the duration of the attack, whether with the medication, whether this chest pain is under control or not, these should be inquired whenever you are taking up this patient on the chair. When you start treating the patient, if you have a feeling that okay, patient may develop a chest pain, maybe because of painful procedure, of course all the procedure has to be what we call done with the painless procedures. If at all the patient is slightly feeling pain, maybe the patient develops a chest pain, then rather you should always think of giving a prophylactic 1 trinitroglycerin sublingual. Then start doing the treatment. If the patient develops a chest pain, then better to stop your dental procedures, just manage this angina pectoris, to give a rest to the patient, and then maybe like you can give one more tablet, trinitroglycerin sublingually to the patient. With this, there's nothing but a vasodilator where this patient chest pain is going to be subsided. Either you can continue if the patient is comfortable, or you have to terminate your dental procedures. And suppose if the chest pain is not subsiding, maybe you have to think of giving a third tablet. And despite that, if the patient is still having a chest pain, then rather you should also take one tablet. Why? Because sometimes these tablets are what we call ineffective when they're given to the patient. That's the reason we should ask the patient to get their medications always, because when we keep in our store or in our dental emergency kit, most of the time these tablets are going to be like ineffective. That's the reason you should always ask the patient to get their medications. If after giving the 3 medications, if the chest pain is not subsiding, then you have to think this could be an MI. So you should always think of in that line, and then better to shift the patient to the intensive care unit where the MI should be immediately managed. Otherwise, it's going to have a little bit damage to the cardiac organ. That is going to be the slightly compromising the patient's life. So when you're taking a patient, angina pectoris or MI, these things should be taken care. And next condition that is most of the time we encounter is a hypertension. As you know, there's a hypertension nowadays very common. Maybe what we call that there's no set standard of blood pressure. We should not, this type of what we call at this blood pressure, we should not treat the patient and all. We have to know that, okay, fine, this could be a mild or a moderate or a severe. Just assess the blood pressure, record the blood pressure of the patient when they enter the dental setup. And once maybe the patient is in the exhaustive stage, or maybe if you feel that some blood pressure slightly raised, rather you have to wait for 10 more minutes or 15 more minutes, and then later second record or maybe third record. If the blood pressure still shows on the higher side, better not to treat the patient, send the patient to the physician and ask the patient to get the hypertension corrected. Maybe it will take 3-4 days for the hypertension to get corrected. Otherwise, not just immediately with the medication it is not going to be corrected. Rather, in case of an emergency situation, only symptomatic treatment should be done. Or if at all very severe, then that should be managed as in the help of a physician, like giving a nifedipine tablet sublingually where the blood pressure is going to be reduced, and treat the patient, and later the proper treatment of this hypertension should be taken care. Adrenaline or not, I tell you, like it is not absolutely contraindicated. Rather, why it's not contraindicated? Because in case of a hypertension patient, if you use LA without adrenaline, the effect is going to be, what you call the duration of this anesthesia is going to be very less. Then the patient starts feeling the pain because of your dental procedure. That pain itself can lead to the release of the adrenaline, and then the patient is going to, again, the blood pressure going to raise. So rather, it's better to use the adrenaline LA with adrenaline only little bit diluted form. Maybe in case of a normal patient, we can use around 20 ml of LA, whereas we have to just limit to the 8 to 10 ml. That's to depend upon what you call this. Dose should be the 200 milligram that we talk in the sense of a milligram. But in case of a clinical setup, yes, rather you have to limit yourself to the using the 10 ml, 8 to 10 ml in case of a hypertensive patient. Otherwise, regularly up to like 15 to 20 ml in case of a healthy patient. So once and then what you call this is not contraindicated LA. Otherwise, regularly LA should be used. And most of the time, these hypertensions are due to this what you call lifestyle or whatever, or it could be due to the any other underlying conditions like cardiac, or maybe it could be the renal conditions. So the points to remember here is that whatever that is recent history of a cardiac arrest or angioplasty in the past 6 months, other conditions like your angioplasty, if the patient undergone angioplasty, then wait for 6 months. If the patient had a MI, yes, you have to wait for 6 months. Maybe history of cardiac arrest. Any history, yes, cardiac conditions, we should wait for 6 months. Otherwise, the chances of having a problem with this patient developing any cardiac complication is going to increase. That's the reason we have to wait for 6 months. Then we have to go for the regular dental treatment. And most of the time, this cardiac problem should be treated with under the antibiotic coverage. So what type of antibiotic you are going to give? Like most of the time, like we'll be giving the amoxicillin, what we call a 3 gram. Either you have to give through the IV route, that's going to be the safer. Otherwise, when you give a 3 gram with the tablets, that is going to cause what you call the complete GIT is going to be screwed up in this patient. So better give IV, or if you have and patient also doubts whether you are going to take the 6 tablets at the same time. No, that is not going to be the distinct. Patient will not trust that way. So rather better change the drug, that is clindamycin 300 milligram. 2 tablets can be given with the patient 1 hour before the treatment, just to prevent this what you call bacteremia, and that is going to protect the heart from developing a subacute banded rectal endocarditis. And once you treat such patients, cardiac patients, and later continue with your other antibiotic coverage, that is regular antibiotic coverage for another 3 days, regular course of antibiotic should be given to the patient to prevent any other subacute bacterial endocarditis in the patient. Now once this cardiac patients, the next condition is going to be the asthma, tuberculosis, and the COPD. Most of the time, like these asthma patients, we are going to encounter in our practice. That is, as you know, that's asthma patients where it's going to the bronchoconstriction is going to be there. Whereas as you can see in the picture, that's the normal airways, whereas blocked airways where because of this either maybe bronchoconstriction, or it could be due to the secretion of mucus plugs because of allergy, or it could be the inflammatory process where the patient will not be able to breathe properly, where patient can become a hypoxic or hypothermia can develop in these patients. So when you're treating these asthma patients, always, or any respiratory condition patients, always we should take up the patient in the afternoon session, because the morning hours, the lungs are going to get cleared by the sputum, and the lungs are going to be cleared by the afternoon. So we should take up these patients only in the afternoon, preferably. When you're taking up the patient, this asthma patient, always ask the patient to get their inhaler medication. Otherwise, because the patient knows whenever with an episode how much meter dose can be taken. So with this, what dose the patient is going to be subsiding the condition if the patient develops an episode of asthma on the chair. So that's the reason you have to ask the patient to get their inhaler meter dose, so that, and when you treat the patient, when you're treating, make sure that the aerosol procedure should be limited, and it should not be directed towards the nasal side, where that itself can cause exhaustion, or what you call a respiratory asthmatic attack to the patient. And when you are treating the patient, if the episode develops, rather don't ever try to keep this patient in a supine position. Don't force the patient to keep it in a supine, because the respiratory condition patients where they rather prefer to sit up in the vertical position with the head down, or maybe chest is slightly lean, so that they are more comfortable in this position. And definitely patient is not going to be in the syncopal position. Rather, this is going for the respiratory condition. You should always make the patient sit comfortable in a vertical or slightly lean position. Whereas when you're treating asthma patients, you should have your asthmatic protocol, your inhaler medications, as well as your IV injectable bronchodilator drug should be available in your emergency kit. Whereas, and point to remember here with the asthma patients is that, yes, that is the same history as what I have told. So whether patient is on medication or with the history medication is under control, when was the last episode, what was the duration of the episode, or these has to be inquired. That gives a slight insight into what is severity of this asthmatic conditions. And then managing the patient, always manage what you call the after session and with the vertical position and maybe the what you call anxiety reduction protocol on we say, but painless procedure should be performed on these patients with a shorter duration of appointment. And point remember here is that buprenorphine containing analgesic is an absolute contraindication that we should never prescribe to the patient in a post-operative period. Otherwise, the patient is going to develop this drug is going to cause again the bronchospasm. The patient can develop the asthmatic episodes. That's the reason you have to always ask the patient to get their bronchodilator drug medication and treat the patient in the afternoon. And meantime, don't ever prescribe this asthmatic what you call buprenorphine containing analgesic to these patients.